Hello, everyone. My name is LynnMarie Jarratt, and I'm with the University of New Mexico School of Medicine. I worked with doctors Kambhatla and Lovato to bring you a really interesting case about a patient demonstrating bilateral hyperostotic skull-based meningiomas that were masquerading as Paget disease of bone. Paget disease of bone, or PDB, is a focal disorder of bone metabolism characterized by an accelerated rate of bone remodeling that commonly affects the skull, spine, pelvis, and lower extremity long bones. By contrast, meningiomas are the most common non glial tumors of the central nervous system and are slow growing tumors. Bone changes can occur with meningiomas, though, with hyperostosis described in up to 20% of cases and typically occurring in the skull base and anterior cranial fossa. A 46-year-old Native American woman with a past medical history of hypertension, obesity, and Bell's palsy was referred to our endocrinology clinic for management of PDB. The patient reported a 3-year history of left sided hearing loss, as well as pain and swelling on the left side of her face. She was evaluated by her primary care provider at the time for possible PDB and underwent a bone scan which revealed increased skull uptake, particularly at the left temporal area suggestive of PDB. CT scan of the internal auditory canal and orbit at the same time showed a pagetoid appearance of the left side of the skull, including occlusion of the left eustachian tube. Alkaline phosphatase levels were normal. However, given the findings on imaging, she was treated with oral bisphosphonate therapy and referred to otolaryngology for management of the hearing loss and eustachian tube occlusion, but was lost to follow up. She then presented to her primary care provider over a year later with worsening left facial pain and hearing loss. She underwent an MRI and a scan of the internal auditory canal, which revealed pagetoid changes in the left sphenoid wing and mastoid segment of the left temporal bone, with a question of dural involvement. Repeat bone scan showed focal uptake in the left temporal bone and extension into the left sphenoid bone with no other sites of involvement. T1 weighted MRI of the brain with contrast revealed dural based enhancing masses in the left middle cranial fossa with a large hyperostotic component and extension along the tentorial leaflet, cerebellopontine angle, Meckel's cave, foramen ovale, and left cavernous sinus, as you can see in image B there on the right. There was a small mass on the right side with adjacent hyperostosis in the middle cranial fossa and greater sphenoid wing. MRI findings were consistent with bilateral meningiomas. On the left in image A, you can see her contrast CT scan showing the bilateral cranial masses with extensive bony proliferation. Her bone scintigraphy scan showing increased uptake can also be seen here below these images. Symptoms of both Paget disease of bone and end plaque meningiomas can vary widely and depend on both the location of the lesion, or lesions in this case, and the stage of the disease. Patients with arthritis, bone deformities, and fracture may be more likely to have PDB, as end plaque meningiomas most often present with proptosis and focal deficits that depend on the tumor location. Key distinguishing features in our case were the dural enhancement seen on MRI and the site of the tumor. Lesions appearing in the convexity, anterior fossa, or sphenoid should always be carefully viewed to rule out end plaque meningioma as a possible diagnosis. Ground glass structure on CT and heterogeneous or speckled patterning on MRI can help correctly identify PDB. End plaque meningiomas are more likely to demonstrate subdural ossification of an enhancing mass on CT and homogeneous asymmetrical thickening of dura on MRI. Dural tails can be especially distinct and useful. Lab findings can increase the probability of PDB if a patient has elevated alkaline phosphatase levels or increased markers of bone turnover, but labs are generally not useful for diagnosing end plaque meningiomas. This case highlights the importance of understanding the clinical presentation and differential diagnoses of PDB to avoid a delay in treatment, which had significant consequences for our patient. Late recognition caused extensive hearing loss and pain for her. Close follow up and careful analysis of imaging is critical when considering either a diagnosis of end plaque meningioma or PDB. Thank you for your attention, and please feel free to reach out to us with any questions.